with your patient's hormones, and you might want to make some notes on it during the webinar. There are many advantages to using a 24-hour urine hormone panel to assess your patient's hormonal health. We're looking at a full day's output instead of just a snapshot in time when you might be measuring either a peak or a valley. We're looking at free hormones not bound, so we can see what's actually available. The 24-hour urine hormone panel includes all 3 estrogens plus estrogen metabolites that allow us to evaluate the 2:16 ratio, methylation, and get some insight into phase 1 and phase 2 liver detoxification. This panel includes a robust adrenal panel that looks at much more than cortisol to get a complete and in-depth evaluation of adrenal health. We can measure growth hormone directly in urine, which is not possible in any meaningful way with any other method, and we see the contribution of enzyme pathways to the hormonal picture. With saliva, pardon me, as with serum, we're looking at a snapshot in time, so potentially getting misleading levels if you catch either a peak or a valley. Estriol is not available in either saliva or serum. Metabolites are not available in saliva. Saliva is good if you want to get a 4-point cortisol, so it has some utility in that way, but it misses all of the information to be gleaned from looking at cortisone and other metabolites. Growth hormone I already mentioned, and of course enzymes are not measured in saliva. Blood is, again, a snapshot in time and often doesn't distinguish between bound and free hormones except for testosterone. There are some important testosterone metabolites that at this time can't be evaluated easily in urine, so we have a testosterone metabolite profile that is a serum test to look at these. A 1-point serum cortisol, which you would get from serum from a single blood draw, is not useful for anything except the extremes like Cushing's or Addison's, long past where you would want to catch adrenal problems. And growth hormone is commonly measured indirectly in serum by using IGF-1, but this doesn't correlate perfectly with growth hormone and can easily look normal when growth hormone is actually low. Let's see, I've been asked here if there is any way to turn up the webinar volume. I can't be heard, so I'm going to get a little bit closer to the microphone. Does this help? Somebody send me a message back. I'm clear. Okay, a tiny bit. Okay. Okay, this is what a comprehensive panel with HGH report looks like. It's generally a 4-page report. For men, it's a 5-page report. We have an extra parameter that we look at with men, and we have some additional metabolites on the women's report in the estrogen area that we don't look at with men. I'm going to dive right into cases here, and our first case is Rose, which is not her real name, of course. Rose is a 59-year-old woman. She is fairly obese and has marginally elevated blood pressure. Her last menstrual period was in 2002, and she's had 1 ovary removed, but she's otherwise retains all of her organs. She's taking a number of supplements, including an adrenal support complex that she got at a health food store, which has primarily panax, ginseng, and licorice in it. She's also taking a diuretic for her blood pressure, an acid blocker, and an SSRI. We include a hormone questionnaire in our test kits, and it's really helpful to have your patients complete them, especially when we're doing interpretations with you. And this is a good place to mention that every 24-hour urine hormone profile comes with a free consult with one of our consulting physicians so that you can get the most out of the report. Rose reports a number of symptoms as severe, meaning that she rates them as a 3 on a 0 to 3 scale. And you can see what they are here. Moderate symptoms are a 2 on our scale, and Rose has a number of significant symptoms in the moderate category, as you can see. And she also reports a number of mild symptoms that may be related to hormonal imbalances. So let's start with Rose's estrogens. First, I want to draw your attention to the reference ranges up here in the upper right-hand corner. We use the luteal range for women who are still cycling and also for women who are using supplemental hormones. For the postmenopause range is for women who are no longer having cycles and not using any hormones, and Rose is not, so we'll be using the postmenopausal ranges in this report. Rose's total estrogens are near the mid-range of the postmenopausal range, perhaps a little higher than they might be otherwise because she's obese, and women make estrone in their adipose tissue. As you can see, her estrone is high out of range for someone in menopause. This leads to her estrogen quotient being low at 0.4. The EQ is calculated by dividing estriol by the sum of estrone and estradiol. Dr. Henry Lemon first demonstrated that women with an EQ of more than 1 have better survival rates after breast cancer with women with an EQ of less than 1. If Rose were a younger woman who was still cycling and had an estrogen quotient of less than 1, I would recommend iodine to promote the metabolism of estrone to estriol. Since she's menopausal and having estrogen deficiency related symptoms, giving her a bias of 80% estriol and 20% estradiol will help move that estrogen quotient up to a more favorable level. So this is what I would recommend for Rose. 1.25 milligrams of Biest in an 80% 20% ratio. And we've asked the compounding pharmacist to concentrate the hormone so that she gets the full dose in a very small volume of cream, 0.1 ml. This is because we want her to apply it to the mucosal surface of the labia majora where she's going to get the best absorption. But this is a really small surface area, so she needs to be able to use a very small amount of cream so it doesn't just sit on the surface, making it both uncomfortable and less effective. We recommend that Rose use the cream days 1 through 25 of the month and then take a break for a few days and resume at the beginning of the next month. These are the estrogen metabolites. I'm going to talk about them individually in a few minutes, but the takeaway message from this slide is that these right here are the phase 1 liver metabolites, and these are phase 2 liver metabolites. And this can sometimes be very helpful in identifying the liver as an area needing support in hormone metabolism. The estrone metabolism pathways can be found on the lower right of your metabolism select steroids chart. I've used the weight of the arrows to display a healthy estrone metabolism in which the majority of estrone is metabolizing to 2-hydroxyestrone, a smaller percentage to 16-alpha-hydroxyestrone, and the least to 4-hydroxyestrone. You can also see that, that ideally a significant amount of estriol would be being synthesized from the 16-alpha-hydroxyestrone. Pardon me. Also note that DIM and I3C will promote the 2-hydroxyestrone pathway, and iodine will promote the formation of estriol. Rose's estrone was high, so it's not surprising that she has at least one metabolite that's high. In Rose's case, it's the 16-alpha-hydroxyestrone, which is a carcinogenic estrogen, so we'd prefer it to be a little bit lower. Her 2-hydroxyestrone, which is protective, is toward the bottom of the postmenopausal range, and this results in a 2:16 ratio that's low. The optimal ratio for the range for the 2:16 ratio is between 2 and 4. Less than 2 is associated with increased risk for developing breast cancer and prostate cancer in men. More than 4 is associated with osteopenia, potentially putting a person at increased risk for osteoporosis. This is because some 16-alpha-hydroxyestrone is necessary for maintaining healthy bone. So even though it's carcinogenic, It's also important for bone health. DIM and I3C, as you will recall, promote the estrone metabolism pathway towards the formation of 2-hydroxyestrone, thus raising the 2:16 ratio, and that's what we'll recommend here. It's worth noting that not every woman needs DIM or I3C, and some women may be increasing their risk for osteoporosis by taking DIM if they don't need it. 4-hydroxyestrone is the most carcinogenic of the estrogens, and we're unaware at this point of any beneficial effects, so we generally want to see this metabolite low. And Rose's is on the high end. It's within the range for luteal, but it's high for postmenopausal. So one of the things that we know is associated with high 4-hydroxyestrone is magnesium deficiency. So our recommendations for Rose would be increase your intake of brassicas, so eat more broccoli. DIM, 300 milligrams BID, or I3C, 100 milligrams BID, and magnesium. I'm asking, is it possible to get a saved copy of the slides? Yes, we will have those available. And you'll be getting an email later that will let you know how to get those. Okay, methylation. So if you look at for 2-hydroxyestrone on your hormone chart, you can see that it metabolizes to 2-methoxyestrone, and that methyl donors such as SAMe are needed as cofactors for this pathway. And here we see how it looks on the Meridian Valley Lab report. 2-methoxyestrone and 2-methoxyestradiol are considered protective estrogens, especially 2-methoxyestradiol, which is a potent anti-carcinogen. Interestingly, it doesn't actually bind to estrogen receptors at all. There are published studies out about its efficacy in treating a number of types of cancer, including renal, pancreatic, breast, prostate, leukemia, and others. It can be compounded into transmucosal creams and included in prescriptions when there's a personal or family history of breast cancer. Looking at Rose's methylation, she appears to be methylating well. Her 2-methoxyestrone at 0.9 is 90% of her 2-hydroxyestrone at 1.0, and we're looking for that number to be at least 25%. Her 2-methoxyestradiol is at the mid-range of the postmenopausal ranges. Is it possible to get studies on the 2:16 ratio? I have a question about that. Yes, we do have some of those. I will look into whether or not they're available on the website, and if not, we'll make sure that we get references to them posted. I have another question here. Any side effects of I3C or DIM to be aware of? This person has had patients getting headaches with it. I have not heard of that. I would say anytime with something like that, I would be looking to the liver. If we're talking about estrogen metabolism and people getting headaches, I would look at liver support. But I'm not aware specifically of I3C or DIM being associated with headaches. The webinar will be archived. There's another question here. How about the audio of this webinar? Because you can't type that fast. We are going to have this webinar archived, so you'll be able to refer back to it, and you'll be able to hear the audio at that time. My thoughts on brassicas. I have a lot of questions here. My thoughts on brassicas in light of frequent thyroid dysfunction. I'd certainly monitor thyroid if I'm giving someone brassicas and or DIM. As with all hormones, it's a balancing act, and if someone also has low thyroid function, then you're going to need to weigh the relative risks and benefits of the different things you're giving to them. Unfortunately, there's not an easy answer for that one. Oh, another question here. How much 2-methoxy estradiol added to the Bias cream for cancer prevention with family history? I want to say 125 micrograms, but I'm not absolutely certain about that. I don't have that on the off the top of my head. I have it, certainly have it on my computer back at my desk, but I don't have that here. You can send an email to info@meridianvalleylab.com with that question, and I will get that back to you. I'm sorry I don't have that at my fingertips. Okay, I'm going to move on now and not take any more questions for a moment so we can get through the report. Okay, progesterone. Actually, this says pregnenolone. Why does it say that? Well, progesterone is doesn't get into the urine very well because of its structure. But pregnenolone is very well established in the literature as a reliable marker for progesterone, so that's what we're measuring. And Rose's progesterone is in the mid-range, so it's fairly well balanced with her estrogens. But since we're going to be giving her Bias to supplement, we also want to supplement her with some progesterone. Also, progesterone may have some beneficial effects on her sleep problems and her anxiety, as well as other symptoms that stem from them. I'm recommending oral progesterone for Rose because there's a benefit to that first pass through the liver, which is the metabolism of progesterone to metabolite that binds to GABA receptors in the brain. And these induce a calming effect. So it's very useful with sleep problems and anxiety. We're going to start with a relatively low dose of 25 milligrams and give it days 11 through 25 each month to mimic the natural cycle that has an increase in progesterone in the second half. Now, if she continues to have sleep problems in the first half, she can certainly take it throughout the month. And she could use additional progesterone as a cream days 11 through 25 if you wanted to maintain that natural rhythm. A lot of that depends on the patient and compliance and just what's going to work. But we certainly do have women who take progesterone throughout the month, not just days 11 through 25. Moving into the androgens. Here's the androgen portion of the pathway, which you'll find on your steroid flow chart on the right side of the page above the estrogens we were looking at earlier. On the 24-hour urine hormone panel, we measured DHEA and its metabolites androsterone and etiolcolanolone, and we measured testosterone and two of its metabolites, 5-alpha and 5-beta androstenediol. Rose's DHEA is high, and her testosterone is at the high end of the range. We more commonly find postmenopausal women with testosterone down near the bottom of the range or even low out of range. It's possible that Rose is taking DHEA on her own and just failed to report it on her hormone questionnaire. So that's something that we would suggest that her doctor look into. If she's taking DHEA, she's taking too high a dose. A physiological dose for a woman is 5 to 15 milligrams a day, sublingual, or twice that in a transmucosal form. Rose's DHEA metabolites, androsterone and etiolcolanolone, are toward the high end of the range and mid-range respectively. And her testosterone metabolites, 5-alpha and 5-beta androstenediol, are also high and mid-range respectively. It's worth noting that the metabolites are high-ish, the metabolites that are high-ish, the 5-alpha androstenediol and the androsterone, are metabolites from the 5-alpha reductase pathways. And we'll be looking at 5-alpha reductase later in the report. Our recommendations are to check for DHEA use, and if she's not using DHEA, then evaluate for Candida, because Candida can sometimes cause DHEA levels to be elevated. We could also consider PCOS with all the androgens being highish and the progesterone relatively low. I'm not sure that that's as indicated here as it might be in some cases. Moving on now to the adrenal hormones, starting with the glucocorticoids. Pregnane, by the way, is it's not a glucocorticoid. It is a marker of a precursor going into the cortisol pathway, and we look at it really just as that, as does she have enough substrate going in? And it's not the precursor itself, it's a marker. So it's it gives us an idea of what's going on, what's going in. Cortisone and cortisol. Well, both of them are within the reference range. They're not in a good balance with each other, and they're not in the optimal ranges. Optimal for cortisone is between 120 and 130, and Rose falls a little bit below that, not much. Optimal for cortisol is around 90, and she's significantly above that. We also want cortisone to be higher than cortisol. Cortisone being storage, we want her to have adequate stores for times of acute stress, and so we're really looking for about 30% more cortisol than cortisone. Higher cortisol levels like this could be a factor in Rose's sleep problems and may represent nighttime spikes of cortisol. These next three metabolites account for about half of daily cortisol output by the adrenal glands, and we want these three metabolites, we add them up, and for women we want to see these between 5,000 and 7,000. Lower than that is indicative of some adrenal fatigue, and higher than that is indicative, obviously, of excessive cortisol output. And Rose's metabolites add up to 10,547, which is beyond even the optimal range for men, which is 8,000 to 10,000. Some of this will be due to Rose's excess adipose tissue, but taken together with the cortisol and cortisone imbalance in this picture, it's a picture of somebody in the adaptive phase of stress before they begin to decompensate. Hold on just a moment. I've got a question here. I'll get to it in just a moment. And these last two metabolites, the last two metabolites in on this page, the 11-beta hydroxyandrosterone and etiocalanone, really just pretty much confirm this high output picture. Okay, now I have got a question here. Let me just get back to it. Will I be talking about how DHEA could be low with high 5-alpha androstenediol and 5-beta androstenediol in a healthy 29-year-old female? I won't be talking about that specifically. Our consulting physicians are available. If you have one of these tests and you have a result like that, you're certainly welcome to call in and set up an appointment for a consult. We want to do that for you. We want people to be able to make the best use of these tests, but I can't answer those kinds of questions in this webinar. And another question, do the optimal ranges come on the test along with the reference range? No, they don't. That's something that we go over in the consults with people. And that has to do with how reference ranges are set in the laboratory and you know, what we have to maintain in that way. Okay, her mineralocorticoids. Mineralocorticoids are really useful in evaluating adrenal health. When they're high-ish or high as they are here, they're indicative of acute stress during the collection period. When they're at the low end of the range or low out of range, they're indicative of chronic adrenal fatigue. And the lower the numbers, the more severe the adrenal fatigue. If you look at your steroid chart, you'll find that these are in the pathway on the left-hand side of the page, and the glucocorticoids that we just went over on the central pathway leading down from pregnenolone and progesterone. So what happens is that survival will always trump reproduction and any other kinds of activities that the body is involved in that are not directly survival related. So in times of stress, more substrate will be pulled down that central cortisol pathway, and you'll see a decrease in the hormones coming out of the DHEA. Now in this case, she doesn't have a decrease, which makes me think that she's taking some exogenous DHEA. So oftentimes when people are under a lot of stress, you'll see the sex hormones low, you'll see the mineralocorticoids low if it's a really chronic case, and that's called the pregnenolone steal. The body is stealing everything it can to go down that cortisol pathway because that's the one that's important for survival. Aldosterone is also a mineralocorticoid, and it is at the low end of the range for a normal salt diet. I don't know what Rose's diet is, but we're assuming that it's a normal salt diet without any other information. There are many things that affect aldosterone, including dehydration, stress, salt. So we use this sometimes as an indicator, I would say, based on what I know from this profile, what I know about Rose, that this is probably related to stress. Being at the low end is worth noting that low aldosterone is associated with age-related hearing loss. In the Tahoma Clinic, they're doing a study on this, and the inclusion criteria, I should say, for people being in the study is an aldosterone of less than 10. So if aldosterone is low, it's worth asking your patients about hearing loss, because it's not something that they'll usually bring up when they come in to talk to you about their hormones. It just doesn't occur to them. It doesn't occur to most of us. And also, it may be something they haven't really noticed because it happens gradually. So they are using aldosterone, supplemental aldosterone, in the Tahoma Clinic for to see if it will improve hearing loss, and some people are having really dramatic results. Some people it's not making much difference with it all. So it's still out. We're still finding out what the results are going to be. So in Rose's case, I would recommend that she discontinue the adrenal support protocol or a support formula that she's taking that includes licorice and Panax, because the licorice is going to keep increasing her cortisol. It's also going to prevent her making more cortisone, which is the storage form, because it maintains it increases the half-life of her cortisol, so it's not going to be going into cortisone. I'd help her incorporate stress reduction tools such as meditation, Tai Chi, yoga, guided visualization, anything she can do to start taking down the stress, really getting to the root cause. I would give her phosphatidylserine or cortisol manager, which includes phosphatidylserine, magnolia, ashwagandha, and theanine, I believe. We have a lot of success with it. I've talked to a lot of doctors who have had a lot of success with it. People usually take one capsule at night, and that's available from Integrative Therapeutics. The general nutrients that we would use for adrenal support and stress: vitamin C, vitamin A, B6, B12, pantothenic acid, and of course I would ask her about her hearing loss. Oh, and also chromium. And we're going to talk more about the specific doses that I would recommend for somebody who's really in adrenal fatigue when we get to the male case. Growth hormone. Rose's growth hormone looks good. It's well within the reference range, and this is a healthy aging reference range for healthy 18 to 35-year-olds. But we want our 50 and 60 and 70-year-olds to be up in that range too, because we want them to be healthy as they age. T3 and T4 look pretty good. They're optimal. Optimal is around 1,000 for each, but we do want T3 to be more than T4. And so this indicates that she might not be converting her T4 to T3 as well as she could. Recommendations would be selenium 200 micrograms or a couple of Brazil nuts a day. Urinary minerals. Her sodium looks well within the reference range. Potassium is at the low end of the reference range. Probably she should be eating more potassium-rich foods. Her sodium-potassium ratio is 2.6, which looks like it's well within the reference range, and it is within the reference range, but it's not in the optimal range. Optimal is about 1.5. Higher than 1.5 is associated as it goes up with increasing likelihood that someone will develop high blood pressure, and we already know that Rose has high blood pressure. So I'd recommend that she increase her potassium-rich foods like avocado, banana, green leafy vegetables. Okay, now we're looking at 5-alpha reductase activity. Rose has high 5-alpha reductase activity, and high 5-alpha reductase activity is associated with PCOS and excessive facial hair in women, BPH in men, and also male pattern baldness, and obesity and insulin resistance in both genders. So we want to get this down in the optimal range, which for women would be midline to low. Some natural 5-alpha reductase inhibitors are zinc, GLA, and saw palmetto. Progesterone also has a 5-alpha reductase inhibiting action, and we're going to be giving her progesterone, so that should also help. Also evaluating Rose for insulin resistance and making appropriate dietary interventions would be indicated. So for 5-alpha reductase inhibition, zinc 30 to 90 milligrams a day, GLA 300 milligrams BID, 2 milligrams of copper for every 30 milligrams of zinc, just to make sure she doesn't develop a copper deficiency. And consider running a glucose tolerance insulin resistance test. That's a test we do here at Meridian Valley Lab where we graph out the patterns of insulin. There are 6 different patterns of insulin resistance that have been identified from normal to straight out diabetes. That's a very useful test. We'll talk more about that in another webinar. Rose's cortisol-cortisone ratio is shifted all the way to the right. This means that the enzyme converting cortisone back to cortisol is working harder than the one converting cortisol to cortisone. There are a couple things that might be contributing to this: stress and licorice. We want this ratio to be dead center at 7, and the second ratio on that page indicates that the same enzymes in a different tissue space, that is the liver, are in pretty good balance. And we pretty much already talked about what to, there's nothing really additional to do about that cortisol-cortisone ratio other than what we've already talked about in the adrenal support section. So, right there, dead center is where we want to see that cortisol-cortisone ratio. So, recommendations for Rose overall: estrogens biased, dim, magnesium, progesterone, oral progesterone in her case to help with her sleep, some stress reductions tools, cortisol manager, nutrients for adrenal support, selenium to help with her conversion of T4 to T3, increase her potassium-rich foods, zinc and GLA or both, for 5-alpha reductase activity inhibition. Ask about her DHEA usage, ask about her hearing loss. Also consider food allergies and gluten intolerance. If you recall back on that first page of medications, she's taking an acid blocker, and acid reflux often is associated with gluten intolerance and with other food allergies. So it might be appropriate to get her checked for that or to at least investigate that. Glucose tolerance insulin resistance test we just mentioned. Increase her potassium-rich foods, zinc or GLA. Perhaps a FSH-LH ratio would be appropriate if you're really concerned about PCOS. I don't think it's really indicated in this case, but that's something that might be considered. And follow-up testing in 6 months to see how she's doing on this new regimen and how she's metabolizing that estrogen you're giving her. Okay, we're about to move on to the male case here. Robert. Robert is a 52-year-old male, 5'10", a little bit overweight, slightly elevated blood pressure. He's been diagnosed with BPH. He's taking some basic supplements, and he's taking finasteride, which is a prescription 5-alpha reductase inhibitor. Robert's symptoms that he rates as a 3 are stress, morning fatigue, decreased muscle size, decreased stamina, and hair loss. Moderate burned out feeling, apathy, sore muscles, decreased erections, decreased libido. Many of these things can be are symptoms of low testosterone, but they can also be symptoms of low growth hormone. Sugar cravings, irritability, allergies, decreased urine flow, increased urinary urge, that's certainly consistent with the BPH he's already been diagnosed with. Okay. Robert's estrogens. His E1, E2, and E3, that's estrone, estradiol, and estriol, are all within the expected ranges, and his total estrogens are mid-range. This level of estrogen is certainly not high, but estrogen in a man always has to be considered in relationship to testosterone, so we're going to revisit this when we get to the androgens. His 2:16 ratio is a little bit low. We want it, just like for women, we want it to be in the 2 to 4 range. Less than 2 is associated with increased risk for prostate cancer, and more than 4 is associated with osteopenia. So we would have Robert increase his dietary intake of brassicas, unless he's already eating them frequently, and would consider DIM or I3C to push his estrone metabolism towards the 2-hydroxy metabolite. His pregnenolone is 429, which is quite healthy for a man. And his androgens are low or lowish. Certainly the DHEA is low. Now this is an anti-aging range, again, for healthy 18 to 35-year-olds, but remember, we want our 50 and 60 and 70 and 80-year-olds to be healthy and age healthily. Robert's 52. So we want him in that healthy aging reference range. His DHEA metabolites are low and mid-range, and his testosterone is at the low end of the range, with his metabolites following the same pattern as the DHEA metabolites, low and mid-range. The 5-alpha androstenediol and the androsterone are both products of 5-alpha reductase activity, and both are significantly low. This is where we want to consider Robert's estrogens in relationship to his testosterone. We're looking here at the aromatization pathways. Testosterone aromatizes to estradiol, androstenedione to estrone. Over-aromatization is associated with insulin resistance, truncal obesity, and gynecomastia, or the development of breasts in men. We determine whether or not a man is over-aromatizing by calculating his testosterone to estrogen ratio. Anything over 4 is good, 6, 8, sometimes even higher. Less than 4 is indicative of over-aromatization, even if total estrogens are in a good range. And here we're going to look at Robert's testosterone of 31.4, divide it by his total estrogens of 16.3, and we come up with 1.92. Oh, sorry, that's not, looks like it's a little not stretched out enough, but it's 1.92, well below the optimal level. So Robert is aromatizing too much of the lowish level of testosterone that he has to estrogen. So he's over-aromatizing. There are some prescription aromatase inhibitors available, but they're hard on the liver, so we prefer to recommend Myomin, which is a Chinese herbal formula, and Chrysin, which comes from the Passiflora plant. Both seem to work well, although the Chrysin is not well absorbed if taken orally, so we recommend a transmucosal cream or sublingual drops. The cream can be compounded directly in with testosterone cream, and we recommend that frequently. We're going to recommend that Robert take 50 milligrams of testosterone to be applied daily to the perianal mucosa. Men will get the best absorption at that location, but if they really object, and some of them do, it can also be applied to the perineal skin behind the scrotum. With DHEA in men, you may get less aromatization if it's applied transmucosally than given orally or sublingually. Okay, moving on to adrenal. Robert's cortisone is a little suboptimal at 103. Remember, optimal is 120 to 130. Cortisol is pretty close to optimal of around 90, but he's not converting enough of his cortisol to the storage form cortisone, probably because he needs most of what he's making. His ratio is going to be shifted to the right, again, as we'll see later. Robert's metabolites add up to 4,085, which is well below the optimal range for men of 8 to 10,000. You can also see confirmation of this in his 11 beta metabolites. Notice that the 5 alpha metabolites, allotetrahydrocortisol and 11 beta hydroxyandrosterone, are also quite low, and this is a result of the 5-alpha reductase inhibition from the finasteride. Okay. Robert's mineralocorticoids look pretty healthy. The 5-alpha THB is low, but this is another 5-alpha reductase metabolite, and this is probably a result of over-inhibition by 5-alpha reductase by the finasteride, rather than an indication of chronic adrenal fatigue. Taken all together, I would say that Robert is showing signs of his adrenals that are getting tired and need support, but are not in a chronic state of adrenal fatigue yet. This is a great time to get in there and provide some adrenal support that will show results much more quickly than if Robert had low mineralocorticoids as well as low glucocorticoids. Robert's aldosterone looks fine. And recommendations for adrenal support for him: B vitamin C, 2 grams BID, vitamin A, 40,000 IUs QD, B6, 50 milligrams BID, pantothenic acid, 250 to 1,000 milligrams BID. For Robert, I'd say probably at least 500 BID. Chromium, 6,000 micrograms a day for 30 days, and then taper to 2,000 micrograms a day. Also adaptogenic herbs, and consider glandulars. And I would also not recommend licorice for Robert because although it will increase his cortisol, it will prevent him making more cortisone, which is storage, and we want him to have enough cortisone. His growth hormone is very low, and again, it's an anti-aging range, but we still want him up there in the anti-aging range. Many of his symptoms, as I had said earlier, are consistent with low growth hormone, including loss of muscle mass, apathy, burned out feeling, etc. Growth hormone hits its peak when the body goes through puberty, and most growth hormone secretion takes place during the night, in the deepest hours of sleep. It declines in age with every animal species that's been tested to date, and by the age of 60, it's usually reduced by half from its level at 20. Growth hormone affects every part of the body. It increases muscle mass, it increases calcium retention and strengthens the mineralization of bone, increases protein synthesis and the synthesis of cartilage, improves kidney function, improves the elasticity and thickness of skin. All of these things are positive. It contributes to the maintenance and the function of pancreatic islet cells. I don't have that one illustrated. Stimulates the immune system and just supports cellular repair and generation. Every cell in the body has receptors for growth hormone or growth hormone factors. And it decreases fat or adipose tissue and promotes lipolysis. Basics for having growth hormone be good are getting deep sleep, adequate protein, vigorous exercise, and resistance training. Glutamine can be helpful in older people, arginine in younger people. And then optimizing the hormones. So all of the hormones will that are listed here in increased levels will generally increase growth hormone. In terms of secretagogues, HCG is the one that Dr. Wright most frequently recommends, and there are certainly other secretagogues out there that I know that a number of doctors that we consult with have used and recommend and have found to be useful in increasing growth hormone. Certainly there are things that can decrease growth hormones: sedentary lifestyle, inadequate protein, poor sleep, and insufficient endogenous hormones. So we're going to recommend that we improve his sleep, optimize his hormones, improve his adrenal function, give him some glutamine, and I would certainly consider giving him some HCG with a growth hormone that low. His thyroid is looking a little suboptimal. I would probably not personally address that first, other than maybe giving him selenium to improve his conversion of T4 to T3. I would first address his adrenals and see if his thyroid might come up on its own with some good adrenal support. His sodium-potassium ratio, just like Rose's, is a little bit on the high end. We would give him potassium-rich vegetables, not give him, ask him to eat them. You know, potassium-rich vegetables and avocados, bananas, all those things that we would want to do to support a healthy lifestyle in general. Okay. Robert's 5-alpha reductase activity is really, really low. And this is what you see with people who are taking finasteride. And this is a concern for us because when 5-alpha reductase activity is over-inhibited and just completely shut off like this, essentially, you can have an actual increase in invasive or aggressive prostate cancers. And there's a very, very good study that looks at this. And this is because when you shut off 5-alpha reductase activity this much, you decrease the production of metabolites that are important in protecting men against prostate cancer and actually protecting against many different cancers. So we don't want to shut off 5-alpha reductase activity entirely. And we would probably recommend decreasing his or discontinuing his finasteride and replacing it with natural 5-alpha reductase inhibitors. Apparently he was on the finasteride originally because his 5-alpha reductase activity was high, or perhaps just because he had PPH and it was assumed his 5-alpha reductase activity was high. So if he needed 5-alpha reductase inhibitors, we would use natural ones like zinc, GLA, and saw palmetto to lower it but to a more moderate level rather than turn it all the way off. And I would also recommend that he do the testosterone metabolites profile so we can see how his metabolites are doing and whether or not he's making enough of those important metabolites to prevent aggressive prostate cancers. Cortisone and cortisol. Cortisol, that ratio is shifted a little bit to the right. Again, that will be taken care of with some adrenal support. The bottom one is all the way over to the left, probably also because of 5-alpha reductase activity, because those metabolites are affected by 5-alpha reductase. Okay, here's our last pathway. And this is what's not included on the woman's report. So this is the nitric oxide pathway, and we're looking at L-arginine and L-citrulline as important contributors to that. And nitric oxide is, of course, important for vasodilation, which is important for erectile function and blood pressure. His total urine nitrates are 820. That's at the low end of the range, which means he would probably be a very good candidate for citrulline therapy or arginine therapy to assist with his erectile function and also assist with his blood pressure. Here are the dosages for arginine and citrulline, and also some 5-methyl tetrahydrofolic acid. 1 to 2 milligrams can be helpful in this as a cofactor. So just summing up for Robert, we're recommending DIM, aromatase inhibition, DHEA, testosterone, nutrients and herbs for adrenal support, supporting his growth hormone, optimizing his hormones basically, improving his diet, reduce his 5-alpha reductase inhibition. So we want to reduce the inhibition and bring it up a little bit. And consider a testosterone metabolites profile. And then I would retest him in 6 months. I have a question here, glutamine at what dose? And I don't have the dose in front of me. I'm sorry, we'll have to get back to you. I see your name. Okay, we will send you an answer to that question about the glutamine, what the dose is. Sorry, I don't have that in front of me. Okay. This concludes our webinar. Meridian Valley Lab and I would like to thank you for participating. Today's webinar presentation will be available on our website archives, and you'll be sent an email regarding how to access the presentation. You can go ahead and register for our next webinar, Allergy Testing in Clinical Practice. That's available to register for now on our website, meridianvalleylab.com. That's going to be presented by Dr. Leah Paz on October 27th at 11 a.m. Pacific Standard Time. Also, please check your email shortly for an anonymous survey regarding today's webinar. Your feedback is really important to us because we want to be able to continue to deliver informative and engaging webinars for you. And if there are any additional questions, I'd be happy to answer them for you if I can at this time. Okay, and I'm seeing, oh, I see a send it to everyone for the dose on glutamine. Okay, we will include that. Our patient experiences is a comment here. Our patient experiences burning with application of the labial bias. Any idea why? It might be a problem with the base. There might be a base incompatibility with the patient. I would try a different base, and we don't usually. Sometimes people have problems with the base in that they don't absorb well, but that doesn't necessarily show up as an irritation or a burning. So I would, like I said, I would try a different base and see if that helps. Another question here, what if someone isn't on finasteride and the 5-alpha is low and they have BPH? Suggestion then. Some people do genetically have low 5-alpha reductase, and unfortunately we don't have any good 5-alpha reductase promoters. There's a lot that can be done to help with BPH besides lowering 5-alpha reductase. It's kind of beyond the scope of what I can answer in this one. It might actually be worth a whole webinar for that on BPH. Okay, let's see. A question wanting to know how and when you can get the slides. That'll be, you'll get information on that in the email that will be coming to you. Okay. Oh, also dose saw palmetto for this male case. Yeah, saw palmetto could definitely be something that would be used as a 5-alpha reductase inhibitor that's a little less extreme than the finasteride. Although you can get over-inhibition with saw palmetto too if you do it in doses that are too high. Another question here. For labial or perianal transmucosal biased and testosterone for men and women, do you always include the full daily dose in only 0.1 ml? Well, no, that really depends. You have to work with your pharmacist on that. If I can get it down to 0.1 ml, I will, but some pharmacists will say, well, I can get that, especially if we're putting a couple things together, I can get that in 0.2 ml or 0.25. I really don't want it to be above 0.25 mLs because that's a lot of cream to get into a small area. Okay. Oh, and dose of saw palmetto for decreasing 5-alpha reductase activity. I don't have that in front of me. I'm sorry. Any other questions? We have about 2 minutes left, and so I will just kind of hang out here for a couple minutes, and see if any other questions show up. If not, thank you all again for participating. We really enjoy doing these webinars, and it's nice to have people out there to do them for. We look forward to talking to you also in our, as you call in for consults. We love doing consults. We love spending time helping you understand the reports and coming up with strategies to really help your patients, especially the most difficult ones. Okay, question. So is there any benefit in running blood hormones? I actually don't ever use a serum for any of the sex hormones. There's certainly things that you want to look at in serum. The LH and FSH, for example, you can't really look at in urine. TSH, the T3 is probably most sensitive in urine, but the other thyroid hormones are good in blood. So there are definitely things that blood is good for. But if you want to get like a kind of holistic picture of somebody's hormone health, the 24-hour urine, I think, is the best for that. Okay, the questions are coming in kind of fast here. Let me scroll back a little bit. Okay, would love more in the specific areas of the reports. I'm not sure what that means. Is the testosterone total estrogen ratio for aromatase only valid for the 24-hour urine? Oh, I see. Can you do that with serum also? I don't know what the you probably could, but I don't know what the appropriate ratio is. It might not be the same kind of, the number that you're looking for might not be the same. And remember, when you're looking at estradiol and serum, you're looking at total, which is bound and free. And so I don't know that you can do an exact ratio with that. Okay, I think that's it. Thank you all for attending, and I hope we see you next month, or you see us next month with Dr. Leah Paz for allergy testing and clinical practice. Thank you.